Assalamualaikum. As part of continuation of acute abdomen radiology aspect, we are going to finish today, inshallah ta'ala, and starting with pancreatitis. Am I hearable?
Yes, ma'am.
So it is the inflammation of the pancreas, and acute pancreatitis by definition is the sudden onset of pancreatic inflammation is the acute pancreatitis. The pain
Ma'am,
is
আপনি স্লাইডটা ওপেন করেন নি, স্লাইডটা ওপেন করলে বেটার।
I did it. What's wrong? I don't know. Would I go back or what? Probably it's now, right? Huh? Yes, screen. Now it's already at hope. The acute pancreatitis is the inflammation of the pancreas. And acute pancreatitis can be defined as the sudden onset of the pancreatic inflammation. And the pain is severe, penetrating, epigastric, and radiates to the back. The pain is from gallstone induced acute pancreatitis is sudden and gets its highest intensity by a few minutes, and pain from alcohol-induced acute pancreatitis gets severe by a few days. In all cases, pain is persistent and relieved by sitting or bowing forwards, and is aggravated by movement, coughing, or vomiting. And the causes, the gallstones, alcohol, traumatic, iatrogenic, like the interventional procedures, ERCP, like those, and the metabolic at the hyperlipidemic states and the hypercalcemic states. What is seen in the acute pancreatitis is very important because the acute pancreatitis has got a presentation like other else conditions. We have to differentiate like the gastric ulcer disease, the cholangitis, cholelithiasis, and other structures around. So what is the pinpoint can be differentiated by imaging. Initially, if it is acute pancreatitis from its initially not superimposed upon the chronic pancreatitis, the X-ray initially may be normal. If the event is superimposed upon the chronic pancreatitis, you may get the calcific pancreatitis, and chronic calcific pancreatitis is revealed in the X-ray, CT scan, and MRI as a calcific echo in the main pancreatic duct or in the pancreatic parenchyma. But when it is acute pancreatitis, from its inception as a entity without any igniting chronic pancreatitis underlying, initially the X-ray may be normal. With time, there may be pleural effusion or atelectasis of the left lung, usually earlier, and is detected in 1/3 of the patient. There may be epigastric ideas of intestinal loops. You see, the intestinal loops are showing air filled, and there is something local involvement of the ideas here in the epigastrium. This dilatation does not follow the whole anatomy of the intestinal loops. This is the gastric shadow and this is the large gut as far we see, and these are causing the local ileus due to acute pancreatitis. And from this scenario, the another thing is with us that if we try to go for an ultrasound in acute pancreatitis patient, there it is a challenge for the radiologist and for the imaging modalities immediately after the onset of the pancreatitis. If there is ileus, ultrasound may miss it. So local ileus is a sign of the indirect sign of the local inflammation underlying. So we may get local epigastric ileus. This is another example of ileus. What is ileus? The area of lack of peristalsis, so that the air gets accumulated there. There may be some fluid, air fluid level also. You see here, there is short air fluid level here, another air fluid level is here, another one is here. So there is no dilated loops. It is the normal caliber loops with short air fluid levels. And whenever it is oriented in a regional area, it implies that there is a local inflammation, like epigastric ileus presents the underlying pancreatitis is a possibility. And whenever there is a ileus of intestinal loops along the right lower quadrant of the abdomen, it may imply that there is possibility of the peritonitis secondary to the acute appendicitis. And whenever it is pelvic for any reason, the pathology is in the pelvic anatomy like PIT or hematoma or other acute conditions like post-surgery. So ileus something speaks about the underlying pathology. Pancreatitis is presenting sometimes with the ileus in the epigastrium, and it may present, usually presents with pleural effusion, at least 1/3 cases we have seen. So left-sided isolated pleural effusion in a patient with acute abdomen always produces a suspicion of pancreatitis. There is a telectasis of the left lung may be present and small left effusion. And the detection of the pleural effusion is poor prognostic issue with a mortality rate of 20 to 30%. And we can go to the intestinal obstruction. Before that, I just want to go for an ultrasound of pancreas so that what would be the pancreatic issue in acute pancreatitis. This is a normal pancreatic dimension under the left hepatic lobe, and this is the apparatus, the inferior vena cava, and this is the aorta in the vertebral column, casting a strong posterior shadow. This pancreas is a comma-shaped structure having a maximum dimension of 3, 2.5, and 2 centimeter in general. This rough estimation gives us an idea that whenever there is any swelling of the pancreas or not. And whenever you come to the field of ultrasound, the pancreas is obscured by the gastric and the colonic shadow. Then you need to fill the air containing hollow structure like stomach with water so that the pancreas is visible under the flowing fluid of water in the stomach. Air is shifted from the stomach. And this is the pancreas. You see what was the normal pancreas? This pancreas has got nothing in between the left hepatic lobe and the pancreatic body or tail. The omental shadows are scattered around and it looks clean. What is here? There is something in between the parietus, the liver left lobe, and the pancreas. The hypochelic tissue here is the fat, the omental migration basically, and the solar pancreas is seen underneath the omental migrated tissue. So this is the case of pancreatitis. The another feature is that what I have said, that chronic calcific pancreatitis is presented with the calculi in the duct system of the pancreas or in the parenchyma. This MPD is dilated with the calculus seen in this main pancreatic duct. So this is a case of chronic calcific pancreatitis. You see, there should not be amount of any sort of fluid around the pancreas, but here this pancreas is seen to be surrounded by fluid along some in the head, some fluid in the body, and the much amount of fluid is accumulated on left side of the body and tail of this pancreas. So this is a case of acute pancreatitis. We have said that the normal dimensions of the pancreas, the head is 3 centimeter roughly, the neck region 2.5 centimeter, and the tail is 2 centimeter. We were talking about pancreatitis, acute pancreatitis. What gives a differential diagnosis of a perforation and acute pancreatitis is the observation of the peristalsis. Whenever the peristalsis in an acute abdomen patient with huge ascites, it implies that there is a possibility of the pancreatitis more than the possibility of intestinal obstruction or perforation. And whenever there is dilated intestinal lobes and increased peristalsis along with fluid, it means that there is intestinal obstruction. And whenever there is slightly dilated fluid and peristalsis runs on, and there is fluid in the peritoneal cavity also, it means there is possibility of perforation resulting in peritonitis, and thus there is ileus throughout. Now we are going to go through some intestinal issues and going to complete this chapter of acute abdomen. Intestinal obstruction is two types, like large gut type and small gut type. What about the small gut type of intestinal obstruction? You will see, you know that the small gut loops are noted centrally in the abdomen. The large gut are seen along the periphery. This is the normal anatomy of the intestine. And the large gut continues along the left hemipelvis and terminates as a rectum and canal to the exterior. The small gut loops, as it is retained at the central abdomen, and the small gut obstruction presents with the features of a small gut and centrally located loops. These centrally located loops are here seen. Normal, there are numericals can be remembered for the small gut pathology. That is 3 centimeter is the upper normal dimension of the air fluid level for the small gut. The wall thickness should not be more than 3 millimeter, and the volvuli conniventis should not be more than 3 millimeter. This is the thumb rule for the small gut obstruction in the intestinal pathology. So whenever we go through the intestinal obstruction in a patient with small gut obstruction, we will get the features of small gut in X-ray. What is the feature? This first we have said that it is centrally located gut loops. The second thing is it has got the special feature of volvuli conniventis. And what do you know that the volvuli conniventis are numerous along the proximal segment of the small gut and gets sparse distally and almost absent in the ileum. And what is seen in the small gut obstruction, these volvuli conniventis presents as series of circles of coils, that is called closely packed coins together. It means multiple coins. If we put one over another, the scenario is seen like that. The volvuli conniventis are the complete circles of the mucosal folds. Maximum density of the folds are in the jejunum and the least in the ileum. So there is volvuli conniventis are seen compact circles of the mucosal folds in the small gut. And thus, the centrally placed bowel loops showing multiple air fluid levels, that is also sometimes called as the stepped ladder pattern type of air fluid levels. That means one is above another, placed centrally, and it is a stepped ladder pattern type of intestinal obstruction. So this is a small gut obstruction is seen in this X-ray. And what would be about the large gut obstruction? The large gut obstruction reveals much dilatation more than the small gut one, and it is peripherally located lobes and it is having rostra. Then whenever the small gut gets dilated, it may even get sized like a large gut loop. Then how can I differentiate between a small gut obstruction, a dilated small gut, and a dilated large gut? The thing is, the large gut has got rostra, and its dilatation is much more than the small gut. The rough estimation is 5 centimeter dilatation of the large gut is the upper normal for the bowel loops, and for the cecum, the maximum dimension should not exceed 6 centimeter. The classical feature of the large gut is the presence of fecal matter, and fecal matter mixed with air is the feature of the large gut. It means the feces has been formed, and the large gut is the classical site for the formation of the feces, not the small bowel. So presence of feces is an indication of large gut. The another is the dimension is much more than the small gut. The third is the peripheral orientation of the large gut, rather the central exhibition of the small gut loops. And finally, the difference between the rostra and the small gut volvuli conventis. The rostra are the incomplete circles of mucosal fold in the large gut. It means it will have an open end rather than it is producing a complete circle. The jejunum has got a complete circle of mucosal folds. These three things will decide that this is a small gut or a large gut obstruction. So this is a case of large gut obstruction. The pelvic and this sinus-shaped orientation means the rectum and sigmoid colon, probably here, and they are obstructed because their dimension is much and there are rostra present in this segment of this large gut. So this is a large gut obstruction. And finally, we are going through the volvulus. What is volvulus? It is the sigmoid colon pathology that causes twisting of the sigmoid colon along its mesentery axis. It means it is twisting over itself at the root of the mesentery. So there is obstruction features are present. Also, there is possibility of the ischemia due to involvement of the mesentery. So, what is there? You see, there is a pneumatic tire-like shadow. We used to describe this part of the large gut as pneumatic tire-like shadow. This is basically sigmoid colon have got no or very sparse rostral markings. That is applied as another term that ārostral gut loop. So ārostral loop, pneumatic tire-like dilatation, and the peak may be up to the dorsal 10, leading to retain at the under the left hemidiaphragm in the chest. And the convergence is towards the pelvis on The opening is along the pelvis and convergence is towards the pelvis. So this volvulus is very much special and very crucial for a patient, usually in the old males presenting with a distended abdomen. And by the way, we can diagnose some of the surgical emergencies just seeing the patient. One of them is volvulus because this patient has got a spatial posture. The patient is not lying on the bed but is entering into the ward sitting position with hyperextension or hyperlordosis. This is very typical for a volvulus to be declared in an old male having a distended abdomen and an acute abdomen state. So with this volvulus, we are going to complete and finishing the session. And that's how we are going to finish the topic of acute abdomen. If you have got any question, you can ask me in the messenger. I am there. Do you have any question? If we don't have any question, we are going to end the class. Thank you everybody for patience hearing.